This talk is going to be on hepatitis B assays. These assays are used for diagnosis of hepatitis B infection, assessment of the replication status, as well as to monitor response to treatment. I do have some financial disclosure because I do receive research grants from companies that make hepatitis B drugs that include some Bristol Myers Squibb, Gilead Sciences, GlaxoSmithKline, Schering, now called Merck, and Roche, now called Genentech. I also do ad hoc consulting for these companies as well. There are different types of hepatitis B assays. There are the conventional serology assays that test for hepatitis B antigens and antibodies. There's also the viral load testing for hepatitis B virus DNA in a serum. There are also molecular assays to differentiate different genotypes of hepatitis B virus as well as for variants of the virus. For today's talk, we will not cover genotype and variants, but focus on serology assays and viral load assays. Before I go to the specific diagnostic test, let's just review what happens during acute hepatitis B infection. During acute infection, some patients experience symptoms of acute hepatitis. They feel tired, they have decreasing appetite, they may have nausea and vomiting, sometimes low-grade fever, and some of these patients will turn yellow or jaundice. A very small proportion, probably less than 1%, develop a very severe form of acute hepatitis with coagulopathy, meaning increase in INR and prothrombin time, as well as encephalopathy, meaning getting mentally confused. These patients have a high risk of death, but if they do survive, they would usually make a full recovery. The majority of the patients with acute infection have what we call a subclinical hepatitis. They may have very minimal symptoms, are not jaundice, and a diagnosis may be missed. Some patients with acute infection go into recovery, and others go into chronic infection. The risk of progressing from acute to chronic infection is inversely proportional to the age at the time of infection. So babies frequently go into chronic infection, whereas immunocompetent adults usually recover. Once the patients progress to chronic infection, which is defined as hepatitis B surface antigen lasting longer than 6 months, they may develop chronic hepatitis with progression to cirrhosis and hepatocellular carcinoma, abbreviated as HCC. Hepatitis B is unique in that the activity of the disease can vary from time to time. So in patients with chronic infection, sometimes they may go through periods in which the virus is at a very low level and liver enzymes are normal, when we say that these patients are in the inactive carrier state. The patients may go back and forth between the inactive state and chronic hepatitis. Obviously, the longer they stay in a chronic hepatitis state, the more likely they're going to progress to cirrhosis and liver cancer. Although most patients with liver cancer have underlying cirrhosis, hepatitis B can give rise to hepatocellular carcinoma even in non-cirrhotic patients. During acute infection, the first marker that we will detect is the presence of hepatitis B surface antigen and hepatitis B virus DNA. The hepatitis B antigen is also a very early marker. As the patients recover, we expect the hepatitis B surface antigen to become undetectable and the hepatitis B surface antibody to become detectable. Patients will undergo seroconversion from E antigen to anti-E. HBV DNA would drop to very low levels, sometimes undetectable, but it is not uncommon that low-level hepatitis B virus DNA remain detected. One of the hallmarks of acute hepatitis B infection is the presence of the IgM core antibody. This usually is the first antibody to show up and is what distinguishes acute from chronic infection. Over time, the IgM anticore is replaced by the IgG core antibody. Now, we hear about the window phase of acute hepatitis B infection, and this is a period in which the surface antigen becomes undetectable, but before the surface antibody is detected. During this time, IgM core antibody is the only marker that we can detect. Well, what about chronic hepatitis B infection? These patients remain hepatitis B surface antigen positive, as well as IgG core antibody positive. During the early phase of chronic hepatitis B infection, they're also E antigen positive with high levels of viral DNA. After years or decades, they may seroconvert from E to anti-E, and HBV DNA may go to a lower level. But oftentimes, the virus is still detectable. I've mentioned that in patients with chronic hepatitis B infection, there's a lot of variability in the virus level and in liver enzymes. We oftentimes describe the natural cause of chronic hepatitis B infection as comprising 4 stages. During the first phase, the patients are e antigen positive with very high levels of HBV DNA but normal liver enzyme. And we say that these patients are in the immune tolerant phase. It is as if the immune system does not recognize the virus, does not attempt to attack and clear the infected liver cells. That's why the liver enzymes are normal. As the patients progress, oftentimes for perinatally acquired infection, when these children grow up and become teenagers and young adults, the immune system starts recognizing the virus as foreign and mount an attack on infected hepatocytes. Here, we would see the virus level start going down and the liver enzymes start going up. And if the patient's lucky, they undergo E to anti-E seroconversion. But the phase of immune clearance or e antigen positive chronic hepatitis sometimes can go on for a long period of time, and the patients would then suffer significant liver injury. After E to anti-E seroconversion, the DNA level goes to very low, oftentimes less than 1,000 international units per ml, and the liver enzyme oftentimes normal. And we said that these patients are now inactive carriers. But it doesn't mean that the virus is gone, because at a later stage in life, either spontaneously or as a result of intercurrent illness, immunosuppression, the virus may become reactivated. And HBV DNA becomes detected again, sometimes at modest to high levels, associated with increase in liver enzymes. And we said that these patients have reactivation or they are in the e antigen negative chronic hepatitis phase. So I've given you a bird's eye view of the cause of hepatitis B infection. Let's now come back to look at individual markers of hepatitis B more closely. Diagnosis of hepatitis B and trying to get clear about all these different markers is perhaps one of the most complicated things about hepatitis B. So this next slide shows the different serological markers of hepatitis B infection. Hepatitis B surface antigen is a marker of infection, but it doesn't tell us whether this is acute or chronic. The IgM core antibody is what differentiates recent infection from chronic infection, being positive in recent infection. Hepatitis B antigen is a marker of higher level virus replication and infectivity. Anti-E antibody is a marker of lower infectivity, lower replication. Hepatitis B surface antibody is a marker of immunity. In patients with chronic infection, they would be positive for surface antigen and the IgG core antibody. In people with resolved infection, they will be positive for surface antibody and the IgG core antibody. Now let's try to do some exercise. In the next few slides, we're going to have different scenarios, and we're going to pick from the answers at the bottom which condition explains that scenario. So for this first slide, you have a patient who has negative surface antigen, negative IgG and IgM core antibody, and negative hepatitis B surface antibody. Well, what would that be? Now, obviously, that person has not been exposed to hepatitis B infection because all the markers are negative. Now, let's look at the next scenario. Here we have someone who's surface antigen positive and IgG core antibody positive, but IgM core negative and surface antibody negative. What's the explanation? Well, this is a patient with chronic infection because the IgG but not the IgM core antibody is positive. Well, what about the next situation? The next situation is someone who's surface antigen positive, IgG core antibody negative, IgM core antibody positive, and surface antibody negative. Well, as I've indicated, IgM core antibody is a marker of acute infection, so that's what this patient has. We now have someone who's surface antigen negative, IgG core antibody positive, IgM negative, and surface antibody positive. So what's that? Well, that's actually someone who has immunity from prior infection. Because when you have exposure to the virus itself, you get exposed not only to the surface antigen, but also to the core antigen, so you make antibodies to both surface and core. Now we have someone who only has surface antibody, no surface antigen, and no core antibody. What's that? Well, that's immunity after vaccination. The vaccine contains only surface antigen, so that's the only antibody that a vaccinee would mount against. Note that if you have immunity from past infection because of exposure to the virus, the core IgG antibody would also be positive. Now, the last scenario that we're going to look at is someone who is surface antigen negative, surface antibody negative, and only has the IgG core antibody. Now, this is somewhat of an unusual situation, but we actually see it quite often in hepatitis C patients. The most common scenario is an occult hepatitis B infection. We now move on to the next slide. So this is a situation which we sometimes call isolated core antibody. IgG core positive, surface antigen negative, surface antibody negative. As I've indicated, the most common reason is occult infection, which means undetectable surface antigen, but hepatitis B virus DNA is often detected in the liver and occasionally in the blood. It is much more common in persons from endemic areas, those with risk factors for hepatitis B infection, and those with hepatitis C or HIV. Although these people are surface antigen negative, if they become blood donors or organ donors, they can transmit infection. This is particularly if the livers are being used for liver transplantation. Rarely, isolated core antibody may be found in someone who is recovered from hepatitis B, but with a very low level of surface antibody that is below detection. And occasionally, it could be in someone in the window phase of acute hepatitis B when surface antigen has become undetectable, but surface antibody has not emerged. Now, these people can be easily recognized because they would test positive for IgM core antibody. There are rare exceptional cases when this is just a false positive test result. So whenever I see someone with isolated core antibody, I always repeat the whole hepatitis B panel to make sure that this is real. Now, another unusual situation is someone who's surface antigen positive and simultaneously positive for surface antibody. Now, I've indicated that's usually not the case because you're either surface antigen positive or surface antibody positive. But we see this occasionally, and in these instances, the surface antibody is not neutralizing. It is usually directed against a subtypic determinant and not the common determinant, and these patients should simply be considered as someone with infection and not with recovery. Now let's look at another situation. I've mentioned in the earlier slide showing the 4 phases of chronic hepatitis B infection that during the last phase, patients are E antigen negative, anti-E positive, but they may have modest to high levels of viral DNA. Well, why is that the case? Why is it that these people are not E antigen positive? Well, it may be that the level of virus replication is low and they're just not making enough E antigen. It may be that they have some E antigen left, but because they have already formed E antibody, the E antigen E antibody are bound as immune complex. But we also know that there is an entity called hepatitis B variants with mutations in the pre-core and core promoter region. These are simply mutations that block or decrease E antigen production, but it does not affect the virus replication. That's why the DNA can still be high. And patients with this profile, we said they're in a E antigen negative chronic hepatitis state. The DNA is usually more than 2,000 international units per ml. It is becoming more and more common because this represents a later phase of chronic hepatitis B infection. The patients are usually older and have more advanced liver disease. Well, enough about the antigen and antibody assays. Let's talk about viral load assay. Well, viral load assay is very important because measuring serum HBV DNA is the only way to directly assess the replication status of the patient. It is important to remember that the virus level can go up and down, so we cannot rely too much on a single reading. It is also important to remember that hepatitis B virus is not a directly cytopathic virus, meaning it's not just a virus causing liver injury, but rather the liver injury is oftentimes immune-mediated. So the immune system has to recognize the virus as foreign and the infected liver cells as foreign and attack the virus in infected liver cells to cause liver injury. Therefore, hepatitis B virus DNA levels do not always correlate with the liver enzyme levels or histologic activity. However, recent studies do show that for patients with chronic hepatitis B infection, if they have persistently high serum HBV DNA level, more than 2,000 international units or more than 10,000 copies per ml, they do have a higher likelihood of progressing to cirrhosis and liver cancer. Well, nowadays, when we talk about viral load assays, they're all PCR assays. They're highly sensitive. In general, we now express the value as international units per ml. Although the assays are very sensitive, there is a lower limit of detection, below which the virus may still be there, but we cannot detect it. So an undetectable result does not mean that there's no virus in the circulation, certainly does not mean that there's no virus left in the liver. And it is important to remember that an undetectable virus at one time might still be followed by detectable level later on. It is also important to remember that in patients with chronic hepatitis B, sometimes the virus level can be extremely high, up to 12 logs. So 1 million is 6 log, 1 billion is 9 log, and 12 log would be 1 trillion. It's very high. That's the reason why hepatitis B patients are more infectious than hepatitis C or HIV patients. So this next slide shows what we mean by the different terminology with the viral load assays. You sometimes see in the lab result lower limit of detection. That's the limit in which the assay can detect the viral DNA. Anything below it, even if it's there, the assay would not be able to see it. Just above that, you would sometimes see a lower limit of quantification. And between the LLOD and the LLOQ, the assay might be able to detect a signal, but it's not enough virus for the assay to give you a real value. So that's usually reported as detected but not quantified. There's also an upper limit, above which we do not get an accurate result, and you get a report which says more than 170 million international units per ml. If you really want to get an exact result, you have to dilute that blood sample and retest. So next slide, as I've mentioned, sometimes we get results back between the LLOD and the LLOQ, and it just means a very borderline positive result. It's not very reliable, so I would usually repeat it again to be sure whether it is detectable or not. I've mentioned that one of the very important reasons for ordering HBV DNA assay is to monitor response to treatment. We now have 7 approved treatments for hepatitis B, and when we treat patients, the way we monitor the response is by the virologic response. We certainly hope to drive the virus down to undetectable. We hope to see e antigen loss and e antigen seroconversion in those patients who were originally e antigen positive. The ultimate goal is hepatitis B surface antigen loss, but that happens rarely. We also like to see improvement in liver enzymes. Now, in clinical practice, we usually do not repeat liver biopsies, so we don't oftentimes assess histological response. If a patient has already progressed to cirrhosis and has liver failure, we will certainly assess for clinical response. The jaundice goes away, the ascites dries up. The majority of the patients that we treat hopefully will be diagnosed before they have gone so far. So the next slide shows what happens in patients who respond. You see that the HBV DNA dropped to undetectable, and if the virus DNA remained undetectable when you stop treatment, that's a sustained response. If the virus dropped to undetectable during treatment but bounced back when you stop treatment, that's called relapse. With treatment, we can either give a finite duration or we maintain the patients on long-term treatment. Now, if the virus DNA is undetectable during long-term treatment, we usually say that that's maintained response. Well, one of the important reasons for monitoring viral level is with the oral drugs, sometimes the virus may select for mutations that become resistant to the drugs. And when that occurs, you see what we call a viral breakthrough, which means that the virus dropped to undetectable or extremely low level, and while the patients are still on treatment, the virus DNA starts going up. When the virus DNA goes from undetectable to detectable or has a greater than 10-fold increase, we say that this is a viral breakthrough. It is important to monitor viral load because if you wait until the liver enzymes start going up and the patient start having symptoms, it will be late because viral breakthrough is actually the first indication of drug resistance. However, viral breakthrough can also occur if your patients are not compliant and do not take the medicine on a regular basis. So let me now finish by saying that what are the take-home messages? Well, we have many different markers for measuring hepatitis B. For diagnosis, we rely on hepatitis B surface antigen. To determine if someone has immunity, we rely on surface antibody. To assess virus replication, we rely on hepatitis B virus DNA. It is important to remember that hepatitis B virus DNA levels fluctuate during the course of chronic infection, and continued monitoring is important even in persons with undetectable viral DNA. Thank you.